Good afternoon, everybody. Welcome, welcome, welcome. Good afternoon, good morning, good evening, good night. Thank you for joining us wherever you are in the world. Today, we have a robust presentation for you. We will be discussing disseminating public voice in Africa with Dr. Laz Eze and Mr. Beniam de Darge. They're both from the Global Brain Health Institute from the University of California, as well as Trinity College. So we're excited to have you join us today. Our moderator today will be our everlasting Dr. Swati Bajpai. So we look forward to having you join us this afternoon, this morning, this evening. And let's do some housekeeping so that you're aware of who we are and what we're doing. For those of you who do not know about the International Council of Psychologists, we are basically here to help support you. For those of you who are new to us, our focus is mostly psychologists with a focus on exploring psychology and human rights, dignity, and justice. In addition to hosting a number of interest groups, our health on health, decolonization on wellness, ICP hosts an annual meeting. This year, we will be having our annual meeting take place on December. We will have it on December 10th from 10:30 Eastern Standard Time. Those of you who are not clear about who ICP is could always find out information about us on our ICP webpage. Our ICP is committed to promoting human rights, dignity, and justice, as well as strengthening collaboration among researchers, educators, and applied professionals globally to further international understanding and the world. Along with our December 10th online presentation conference, we will also have our annual conference taking place at Rotterdam, Netherlands on April 3rd through 5th in 2025. We encourage anybody who's interested in presenting to submit an abstract through our web portal. Deadlines for the abstracts will be until today. So you still have time. Depending on where you're in the world, you're more than welcome to join us to be able to submit your abstract. Housekeeping rules. Please be aware that the webinar has a Q&A function. If you're able to find it on the bottom of your screen, please feel free to add your questions in that spot. You could also ask questions in our chat spot. We will be taking turns making sure that all your questions are responded to. Please note that certificates of attendance will be sent automatically to all who attend at least 40 minutes of this webinar. We will automatically be sent to you, so please do not hesitate in being able to. Please be patient with us as we try to get to you as soon as we can. The webinar will also be available online once we are able to get it processed. So welcome again. So without further ado, I'd like to pass it over to Swati Bajpai, who will tell you more about our presenters for the day. Thank you. I look forward to seeing you later again.
Thank you, Dominic, for such a wonderful, warm welcome and morning's greeting. So I would like to say that this is our final webinar of the Health Psychology Interest Group. We had an amazing 3 webinars, and I'm very, very happy that we are hosting this last seminar of this series on the International Day of the Older Persons. And the theme of this year of today's date is Aging with Dignity, which is basically the importance of strengthening the care and the support system of the older persons worldwide. And I'm very pleased to introduce Dr. Laz Eze and Beniam Daniel Darge for accepting the invitation and giving their presentation. So just to introduce, Dr. Laz Eze has received his medical school training at the University of Ibadan, Nigeria, where he graduated with Medical Students Prize in 2008. He undertook his postgraduate studies at the University of Kentucky, United States, where he obtained a Master's of Public Health degree in Health Policy and Management and a graduate certificate in Global Health. And he has just finished his Global Brain Health Fellowship from Trinity College, Dublin, and he's back to Nigeria and working with his initiatives on brain health. And our next presenter is is Beniam Daniel Darge, who is a postgraduate in mental health from Jima University, and he's also completed his bachelor's degree in nursing from Urban Minch University. And he's working as a lecturer and researcher at Urban Minch University and is involved in academic research, clinical, and community service with a specific focus on brain health. So I welcome you both, and we look forward towards your presentation. So without further ado, I would like to give the platform to Dr. Laz for his presentation.
Thank you very much, Swati. Bringing up my slides shortly. Okay. Okay, good afternoon, everyone from Nigeria. Today's our 64th independence anniversary. So it's kind of national celebrations, and I'm really delighted to be part of this webinar. Thank you very much, Swati and ICP, for getting me involved. I'll be speaking to this topic, disseminating public voices in Africa. A bit of a background, Swati has already given my professional background, but I also do some stuff in the media. I've done radio shows on health for like 5 years, 5 consecutive years. I've done TV shows for 3 years, over 120 programs on TV, and also done a lot of community work. So I'll be taking this more from the perspective of not so technical, professional angle, but as a community mobilizer and someone that tried to get people's voices and opinions on our health situation, government policies, and also feedback to healthcare providers. I've used this picture a number of times. I know Swati may have seen it, so this is a picture I took at a public health facility in a rural community in Nigeria, where this person, the mom was about 80 years and having signs of cognitive impairment. She was lying on a couch and fell down. They were taken to the hospital. After seeing her at the clinic, they were to take her to the ward. There was no ramp. And so even if they had a trolley, no ramp because it's just steps. So with this picture, we were able to do some community advocacy, and within a couple of months, the community people contributed money to build ramp in that hospital. So just using this to get attention on some things how certain community voices could be communicated, with minimal technicalities. So this is essentially about Nigeria with some health indices. I'll quickly go from there. So in getting these community voices, one might look at communities from different perspectives. There is a community, if you're looking at elderly people, or you might look at community of people living with brain health conditions. There are community of people living with diabetes, community of people living with different kind of situations, but there are also like some kind of geographical communities, which could be a street, which could be a university campus, which could be a hospital, which could also be community as organized. But in Africa, we have communities that are largely geographical with leadership structures, and this preceded colonialism, before the Europe-like kind of governments we operate at the moment. You have governance structures at the communities, and they are still there. So those governance structures within different communities organize them to reflect their culture and drive development, engage the government at different levels, and also engage healthcare providers. So to getting these voices, I posit that it could start with having community structures for health, because health is total. People's understanding of health has to do more with the clinical definition of health, but not so much about the psychological component, So with community structures for health, where within the same governance structures, you have health committees whose responsibility is to drive awareness, be able to get voices of the people and channel those voices to the appropriate places. So it could be in form of providing feedback to health workers on how they perceive their quality of care. It could also be providing feedback to the government at higher levels on their needs, not just for the health facility, but also for the community. And this is really essential in caring for elderly people, most of who stay at home. We don't have the practice of putting old people or elderly people in care homes. So they stay with families where support is being provided, and many of them might not be strong enough to go to a health facility to access care. So the care is taken to them in their respective homes, so it becomes very pertinent that the voices, their needs, those feedback are gotten at that community level, and having a channel to communicate it to the appropriate quarters where their voices will matter and their voices will be heard, whether in form of research, whether in form of feedback for care. So this is one of the rural communities I went to, is in the health facility, and we met with the health committee. The documents in my hand are policy documents of government that explain their roles as community, for them to know that, okay, yeah, there are certain responsibilities. Many of these policies are made, but the people who are to implement it at the lowest level are not even aware that those documents exist. So part of what we did in some communities was, okay, engage their health committees, give them this document to understand their roles better and know how they engage with the primary care facilities. And from those engagements, then some of them call town hall meetings, or they call a meeting at the village square, because these are rural communities. So wherever their meeting point is, they invite members of the community to educate them. So some of them have people they are caring for at homes, and some of them have, different needs. So it's at these kind of meetings that people express themselves. In Nigeria, we have more than 500 different languages that you're speaking this, you don't understand the next person, So if you use English, for example, which is the official language, certain voices might be lost. So, but this kind of engagement give people the opportunity to speak in their dialect, in the language they understand best, and be able to get those voices. This engagement is also used in population research, where you need to apply a questionnaire and something. So it's usually easier to engage at the community level. They fix a date, convene the people, introduce them, and say, okay, we have these people, they want to do this research. This is why it's important. The PPV, the public patient voices, is not like something that is widespread, but is involved in certain ways in some of health program interventions, where the opinion of the community is got through this kind of strategy. So, and following up from that, apart from those direct engagements, on my left is a vehicle with speakers where you record messages and drive around the community, play those messages in their dialect. The place is a local market where people bring fresh farm produce and sell, mostly in the evening time, so drive around, give those kind of messages based on what you want to pass across. And get feedback, get those voices during other community engagements, So using some of these local methods, yes, there is the mass media, there is other this thing, but there are some people who may not be able to get some key messages that concerns their well-being if you don't deploy this kind of strategy in some kind of locations. And in this kind of stuff inspire action. For example, the picture on the right is showing us with some equipment, Sphygmo manometer hand washing facility was a health post. The community doesn't have a health facility. The nearest one is far. Through the messaging here, they got inspired to take actions and had meetings, made some contributions. Somebody donated their building as a temporary site for them to start a health post. So my organization now got some of these things as a way of supporting them or giving them incentive to do better. And at this meeting, they were able to express themselves, and we took note of those voices, which we also did some documentary that we put on the YouTube, and also put it on TV, where policymakers were able to get those voices. Another strategy that I've used in the course of my work is also the community health workers' involvement. Some of them, because you might have some of them not in the right numbers, they are overworked, so communication is usually one-sided, where they are the ones usually talking to the patient and not getting the feedback from patients. Some based on training, they don't feel the patient should have a voice. Others based on, oh, we are too busy, we don't have time for that kind of conversation. So through the training them to know that there are policies on this, and this is also how it could help the quality of care, how it will strengthen make the patient feel better. Those feedback will also help them in improving their practices, and also if they want to do a research, they will be able to get more accurate responses from the community. It helps to save resources for more efficient utilization of resources when we engage these voices. So when we train them and bring these perspectives, various categories of the health workers that work at that level, it kind of helps to do some kind of improvement. So involving those community providers for them to understand the need for this, getting the patient's voices and community voices, the people's voices, how it matters in healthcare, is one of the engagements that we've been able to do, and which for places where we deployed that has proven to improve the relationship between the care providers and the communities. The one we're a bit more used to, use of mass media, on the left is, the TV program I was doing up till last year, before I went to GBHI fellowship. Then on the right was the radio program I did between 2014 and 2019. I also did another program like 2021 to 2022, but more, I had those who were fully on ground, and I do join virtually. So these ones also help to get those voices, especially when it's interactive. Like on a day like this, if you have a topic, mental health is an area that is still evolving, that people understanding is improving, and the media played a great deal. For instance, in Nigeria, we got the Mental Health Act in 2021, and in 2020, National Mental Health Act, which is an act of parliament. It took a while before it got passed, because largely people don't quite have full understanding what mental health is. Usually they start thinking of psychiatry or madness whenever you mention mental health. So, but with the use of the media, social media, a lot of engagement, Policymakers tend to watch more TV. Young people tend to operate more on social media. Then radio, people in the rural communities tend to access radio more. So none of these channels is perfect, but there's some sort of media convergence that has to happen, where you start selling things on social media, and from there you take the contents to both radio and TV, and with that, everybody, and the one you're doing on radio and TV, you're also streaming it on social media. So everything tends to speak to each other. So those interactive programs help people to be able to get the voices heard and documented and used to influence our practices, and also used to influence policies. Because I work more in the policy space, I kind of articulate this more to influence how government assess the policies that's been made, and also the how people feel about the implementation of those policies and how they could be improved upon, and also get feedback on how healthcare providers are able to adhere to the policies and the kind of gaps that we may see going forward. Sorry, my system, I don't know if it's freezing or what. Okay. So, and most recently, this was just yesterday, we had the World Heart Day event, and did a movie premiere. The movie was released today on YouTube, Reboots. So, and when we had the premiere, we had a multidisciplinary team in the room and had them watch the film, had a roundtable discussion afterwards. So we had journalists, we had actors, we had health professionals, we had comedians, we have volunteers, civil society people, and all of that. So just kind of get their perspective on the content of the movie and whether they thought is a good way to pass messages and get people's feedback. So today the movie is up, and we're already getting some feedback on YouTube, where some persons were commenting, although most of those feedback, we find it educative, we find it educative. So we think that this is also a communication platform to get certain messages passed out. But in getting the voices, getting feedback, maybe not on the general level, you may not get best of the feedback, but for targeted audience or targeted population that need to get their voices, if you bring them to a room and they get to watch a movie with a message that we want to pass, they'll be able to give an instant feedback on what they think about it. This could also work in research, so yes, we write our beautiful proposals and methodologies. Some of these ways, especially when you are dealing with not so educated populations, where you might have some barriers with people giving consent and all of that. If the purpose of the research and some kind of message could be put in a form of short film acted out, and the target people were made to look at it and say, okay, what do you think about this? Maybe it could help for them to, because when you're watching a film, you're not just listening to what's being said, but there are visuals, and every aspect of it is communicating something. So it gives some nonverbal communication that helps to deepen understanding. And without understanding, the quality of the feedback will definitely be better. So it's usually said within the advocacy space, okay, nothing about us without us, so the public voices, the community voices, nothing about the community without getting those voices, and one top political actor in my country would say, you don't barb somebody's hair in the absence of the person. So they don't barb a man's hair or a woman's hair in their absence. So this goes to push how relevant these voices are and in getting things done. And the principles are generally similar, but in different locations, the strategies might differ to get the best of it. So thank you very much for listening.
Thank you so much, Laz. Take the questions at the last so we can hand it over to Beniam.
Can you all hear me now? Okay. Good morning, good evening, and good afternoon, everyone. My name is Beniam, as previously introduced, and I'll be talking for some time about mental health in Ethiopia, about in general mental health care in Ethiopia, with the lens of equity and disparities in the resource limited setting. And when I say equity, this is the definition of equity that I'm basing my presentation on, which as defined by WHO is the absence of unfair and avoidable differences in groups of people, whether those groups are defined socially, economically, demographically, or geographically. And disparities are also described as preventable difference in burdens of disease, injury, violence, or opportunities to achieve optimal health. So I'll be framing the whole of the presentation in this sense. When I introduce Ethiopia, Ethiopia is a country in the eastern part of Africa with a population of close to 110 million. And in the past years, we have seen significant increase in the life expectancy, which is now around 73 years at birth, and 48% of the population is illiterate, and there are more than 80 ethnic groups with 56 plus languages, and a huge proportion of the population living in rural areas. The healthcare system in Ethiopia is organized into a three-tier system. At the bottom is the primary healthcare system, which in urban areas is organized into a health center, which serves around 40,000 people in the catchment. But in rural areas, there are three levels in health posts, health centers, and primary hospitals. And there's a general hospital, which serves about 1 million people. And then there are tertiary hospitals, which are limited in number, but are supposed to serve close to 5 million people. Ethiopia's healthcare system over the past 20-30 years has seen a significant improvement with major achievements in terms of reduction in maternal and child mortality, with expansion of community-based healthcare delivery system, and as I mentioned earlier, significant increase in life expectancy. But mental health or brain health service remain significantly underdeveloped. This is a picture of the only mental health hospital in the country, which serves the whole population, which is first established in the 1930s, with service provided mainly by psychiatrists from the Soviet Union. In the 70s, the first Ethiopian psychiatrist was trained in the US and started providing service, and then the expansion of mental health service in Ethiopia continued. Currently, this hospital, which was established in 1930, still is the only mental health hospital in the country. In general, according to the data in 2019, 25% of the hospitals and 6% of the primary health care centers provide brain health or mental health services. 15 hospitals in the country provide inpatient mental health services. It is estimated that around 111 psychiatrists are present in Ethiopia practicing, and 46 clinical psychologists. And these are master's level clinical psychologists, and we don't have data on the number of clinical psychologists at the PhD and postgraduate level. When we see the disparities in the mental health system, as I mentioned, 79% of the population is living in rural areas, but most of the psychiatrists and psychologists that I mentioned earlier are practicing in the capital, and the rest are practicing in major urban areas. There are around 800 psychiatry beds or mental health beds or inpatient services, and 550 of them are in Addis Ababa, and only 90 are available for the rest of the country. So we can see the urban and rural divide. Sorry for the noise in the background. So when we see literacy, again, showing the disparities, 23% of the population in rural areas is literate, and around 70% in urban areas, and all the other socioeconomic measures are also showing disparities in terms of poverty, food security, access to healthcare, and awareness are all worse in rural areas than in urban areas. And the other source of disparity, like cultural and religious beliefs, are also different, including assumptions about causations of the problem, help seeking, stigma, and social isolation, are all different in these populations. There have been several efforts by national and international stakeholders in addressing these gaps and disparities. One of them is the WHO's MH Gap Intervention Guide, which provided training to around 300 or 400 mental health professionals in a task-shifting approach to train general health practitioners into providing at least basic mental health care services, which was implemented since 2010 in Ethiopia and is showing some results, but still the disparities continue to exist. And the Ethiopian government and the Ministry of Health has started to design a national mental health strategic plan. We don't still have a mental health act or a mental health policy, but this is the first step in moving toward a more sustained mental health action plan, which is a national mental health strategic plan, which will last until 2025. And here are some of the challenges. As some of you may know, Ethiopia has been going through a large conflict over the past few years, and of course, it's hidden behind all the other conflicts going on around the world, but hidden behind the shades is one of the worst humanitarian crises in the 21st century, which killed hundreds of thousands of people, innocent civilians, and also has destroyed almost all of the public health infrastructure in the conflict-affected regions. And some studies are showing about the mental health, the psychological, and the social impact of these conflicts. These are some of the published research available in the topic, but we're still yet to see the true impact of the conflicts had in the mental health and sexual well-being of the individuals, because there has been a lot of distraction, a lot of family separations, and gender-based violence was also hugely prevalent during the conflict. Now, when we come to the solutions, me as an Atlantic Fellow, as a lecturer and researcher, I have been trying to play a role in the solutions, including in our discussion events, in public health education, and in some projects that aim to integrate mental health and sexual services into the primary healthcare system. These are some of the awareness creation events that we held in conflict-affected areas. And the other approach that we're following is collaboration with international and local organizations in establishing primary healthcare service provisions in these conflict-affected areas. The pictures that you see here are some of the clinics that we were able to establish in these conflict-affected areas, and some of the collaborations that we're trying to build. But the true solution would be collaboration, education. As I said, we have only 46 clinical psychologists at a master's level, so the more training of individuals at more specialist levels, establishing of training programs would be the ideal next steps to take in order to tackle the huge burden of mental health and psychological problems that our population is going to face in the coming years. And thank you so much. This is that.
Thank you. Thank you so much, Beniam, for giving this a brief talk about the healthcare system in Ethiopia. And I have a couple of questions for both of you, but before that, I just wanted to see that if you have any other questions here. We have one question here with regards to helping elders in Nigeria, in addition to helping improve access like ramps in contrast to stairs, community engagement in native dialect, radio, and public programs. What are the traditional approaches to caring from elders in Nigeria and Ethiopia? It's for both of you. And how is that integrated into contemporary healthcare delivery? For an example, traditional medicine, including ritual, ceremony, prayer, as well as who delivers care in traditional communities, how it is integrated into contemporary healthcare delivery. That's one question.
Do I go first?
Yeah.
Okay. Yes, thank you very much. That's a good question. How do we care for elderly in Nigeria? At the moment, people when they get older, stay with their families. We operate extended family system, where family is not just considered as father and mother and children, but cousins, grannies, different kind of relatives, in-laws, are all considered as family, and people tend to support. The demography is in a way that 7 out of every 10 persons in the population, particularly the elders, live in rural areas. So the urban population tend to be more of working class, very active, then people tend to retire. So when they get older, they access various forms of care, some the traditional, some the orthodox, especially if they could afford it. Although there are moves for healthy aging, there is a National Senior Citizen Center that is kind of pushing to prioritize older people in health insurance so that they could afford better quality of care. But that is not universal yet. So a lot of persons still have to take care of themselves based on what they could afford. So how is this integrated? The health system, the National Health Act in Nigeria, enacted in 2014, kind of created a health system that recognizes various forms, from the Federal Ministry of Health to the states, to the local government health authorities, to the community health committees at the community level, alternative medicine, traditional medicine, private care providers, they are all part of the health systems are recognized. So they are licensed to provide services, but there are places where regulation is poor, that people who may not have updated their license or may not even have license will get into practices, especially in hard to reach communities where you do not have a lot of presence of healthcare providers. So, but through the community governance structures, which is part of the health system, they communicate with the primary healthcare. So, and that's at the primary healthcare facility level, there are health workers that have community health extension workers who are part of the health workforce. So their job is to get to the community, interact with people, visit elderly people at homes, and even get those feedback to the facility. Sometimes if there is high need, they could organize medical outreach, or also report data based on what they are finding out. So it's not very strong yet in mental health care because of understanding is not that much. So when it comes to brain health issues, the low awareness and low understanding, it still gives room for some kind of misconceptions, but it's more widely practiced in physical health conditions, more than it's done in mental health conditions, which is quite huge because sometimes loneliness, and many other things. Someone that is to be very active and perhaps for one reason or the other is less active could make some get into depression, have some psychological challenges, and they get not much help from it. So it's still a gap that the health system is trying to deal with. But the decentralization of the health system in Nigeria makes it in some places is strong. Maybe you have a state where you have better quality of leadership. Things are working much better. You go to another part of the country where the leadership is poor, or human capacity, or there are environmental factors that make people not to go there that much. Things may actually look worse. I don't know if this answers the question properly. Thank you.
Thank you, Laz. But I just want to extend this question because my question was also on the similar lines. I wanted to just curious to know basically, are there any mobile unit or community-based healthcare services available to address these gaps? Because your one first pictures gives me jitters, like he's carrying his 80-year-old mother and bringing to the hospital for the services. So it's like, is there any mobile unit which is available which can go to the rural areas and give community services like this? And same questions for Beniam as well. Is it available there? And how often people are able to actually, even if it's available, how accessible it is? That's the main question I wanted to ask.
Right. Yes, there is, but it's not universal. So in some locations you could find this, especially where you have active community participation, because there is the emergency transport system that is structured working with communities to respond to emergencies that tend to get more attention than you do get for some of these cold cases that may not quite occur from emergencies. So in some locations, they get it started. They have even tricycle in some places, to help with this. And sometimes it's not sustainable. You might have a state governor who started that. It works well in the administration. A new person is elected with different priorities, and that may not work out effectively. So it's something that operates in some areas, but not everywhere.
Okay. Yeah, I agree with Laz on many of the points that he raised about accessibility of mental health care for elders. With your last questions, with the availability of mobile healthcare teams, it has become more of a common practice in the past few years in Ethiopia, where especially with implementing partners that I used to work with, or I still continue to work with the international organizations, especially in, as I mentioned, conflicts and natural disasters like floodings and droughts have made the primary healthcare system almost non-functional in many parts of the country. So healthcare delivery in most of those parts have been almost entirely dependent on mobile healthcare teams, which we usually have primary healthcare physicians, midwives for the maternal and child health services, and also mental health professionals going into these communities, having medicines and providing those at least basic level of care, and then transporting those who need advanced care into the central hubs where advanced care can be provided. But still, it is dependent on the availability of an international organization or funding for the local healthcare administration to provide those services. And it's, as Laz said, limited in most areas and available in some areas. But that has been one of the approaches that I used in my also implementation in my collaboration with some of the organizations.
In that same question, I'm again curious to know about what are the traditional approaches of caring for elders in Nigeria and Ethiopia. I think many times, people go towards the traditional way of caring for elderly and do not take on to the contemporary healthcare delivery. So how do you deal with that? In that scenario, a mental health professional is required to give them a lot of understanding and awareness about the difference between the traditional and the requirement for the contemporary healthcare. So how is that system in Nigeria and as well as in Ethiopia? We can go with Beniam first.
These are traditional communities, really conservative traditional communities. So that of course there's a traditional medicine and traditional way of caring for people. So care usually starts in the family. So family is usually, as Laz mentioned, the primary source of support and care for elders or anyone with a mental health problem. And if it gets out of the family, usually people go to faith-based or spiritual or traditional healers that usually provide these services in Ethiopia. Most of the country is either a Muslim or a Christian community. So in the Orthodox Christian the spiritual beliefs, the holy water is the way for any physical or mental illness. So people are usually taken to these facilities where they would be staying for weeks, months, or even years to get those treatments. And in the Muslim community too, and they go to mosques and sheikhs to receive this care. So that has been the way of treatment for so many years, and with the availability and increased availability of modern or biomedical care, it is now becoming a challenge in creating the awareness in the community that this treatment is available in a hospital or in a health center that they could receive. But still there are people who start medication and then choose to go to a special treatment center and then come back to the hospital once their condition is severe enough so that it's beyond treatment or it's challenging to treat those conditions. One of the approach that's being used by some universities, including mine, is to collaborate with these spiritual care providers and provide service at those sites that to teach with the religious leaders that the modern treatment and the traditional treatments are not indicated to each other, so that people can use both the treatments. So we have been trying that approach. It is being effective in some places where we're even having temporary clinics in holy water sites and in mosques, so that people can at the same time get the traditional, the spiritual treatment, but also take their medications. But it's still something that's evolving and challenging, but that's one issue in Ethiopia.
It's really interesting. And how about in Nigeria, Laz?
Yes, it's quite similar to what Beniam has described. The traditional setting for a lot of mental health conditions, people think is a spiritual condition, and their response is a function of their faith. So you have Christians, you have Muslims, you have those who are classified as traditional religion, even though there's no book, holy book, as you could have another. So it's built based on the people's system, belief, culture, which differs from place to place, So in this situation, those Christian clerics could be involved, and they organize prayers and all of that, motivational talk using the Bible. Muslim clerics tend to do the same in locations where that is dominant. And the traditional folks also tend to consult the oracle, or the gods, with priests whose job is believed that they could see some mystic powers and all of that. So, but what we've kind of realized is one might think that there are different factors to it. There's some that are based on out-of-pocket expenditure for health is over 70%. So because going to seek orthodox care might cost more, and in believe, oh, these people don't have solution for it. You can't say, okay, take this medication and everything is gone. So it just be, oh, it's beyond the orthodox thing. So even some people from hospitals, they get to the spiritual places From spiritual places, they have maybe some physical health complications. We find them going to the hospital, so, but most of the time there's just this belief that, oh, this is spiritual, then they'll get to do something. There is no much integration of mental health, unlike physical health or like in obstetric care, where people go to traditional birth attendants and especially in hard to reach areas where you don't have skilled health workers. So these traditional birth attendants are trained, and if they have patients with signs of complications, they refer to facility, make a call, and there are ways to transfer that. But in the area of mental health, there is not that synergy. There's still this one seeing the other ones as not knowing what they are doing, So and there, to my knowledge, there is no much referrals like from traditional and say, okay, no, go to health facility, you might need to get some help there. So it doesn't quite happen. Referrals are usually based on physical health complications. Maybe there is bed sores or there are other physical manifestation of the illness. That's where you could say, oh, they don't want them to die in that location. So they could refer them to the hospital. So that's the situation.
Okay, thank you so much for such a brief, telling me the answers regarding this. But I have many questions in my mind, which I'm going to ask Laz maybe after this. But one question is also there over here: is healthcare considered a right in Nigeria or Ethiopia, supported / funded by the government, or it's the private providers?
Okay. If I may start, so healthcare in general is a government, is supported or funded by government. We don't have like a universal healthcare or like a health insurance system that is well developed. We're starting a community-based health insurance system, which is again largely subsidized by the government. And the private sector is still developing, but it's not like independent enough to take over the government provision. So healthcare is largely supported and funded and administered by the government. But it's not free. People have to usually pay out of pocket. If they go to a government facility, the cost will be lower. And if they go to a private facility, the cost will be higher. But if they go to the government facility, the quality of the care that they receive is significantly lower than what would they get in a private facility. But generally healthcare is managed by the government.
Extending to this question, I just wanted to ask both of you, is the political forces are also associated with the healthcare services or a delivery in your countries? Does it actually affect the integrated system of the healthcare in your countries if there's a change of a political power or something like this, or any international affairs which are going on which disturbs the whole system?
Okay. Thank you. So, responding to the first part on whether health is a human right, yes, it's considered a human right in Nigeria, but our current constitution doesn't expressly capture it as such. Previous constitutions did. The current constitution recognizes rights to life as a fundamental human right, but didn't expressly list right to health. But it's inferred that, for you to achieve right to life, then you must have right to health. Yeah, government is big in the health sector space, given how, the health system evolved, because colonial days, providing healthcare is part of, the social services that were provided. Churches, different missionaries also created health facilities and all of that, doing medical outreach. So when the government they gained independence, you know, we also retain that kind of system. So I'm being a British colonial, so the structured around the NHS kind of thing at the beginning. So, but at some point has evolved. So right now you have public, you have private, you know, side by side, and they play at every level. You have primary, secondary, and tertiary care in the public. You also have primary, secondary, and tertiary in private. Even though the public tend to dominate in terms of tertiary care, in front of the teaching hospitals and all of that, but private is gradually growing. You know, so people assess the one they think they could afford. Most of the experts are found in the tertiary health facilities, in the government teaching hospitals or federal medical centers. So that's going to, and change of government, yes, it does affect in some ways, especially at the subnational levels. You know, one thing with health in our space is there's a proverb in my language that say a goat that's owned by many people or being fed by many people usually die of hunger. You know, so if you, Beniam, and Swati are the ones to feed the goat, so I may assume, oh, well, Benny will feed it, you know, so Benny will assume Swati will feed it, and the goat might just be hungry for most of the day. So because health is considered responsibility of every level of government, federal, state, and local, you know, so without some very clear description and roles for each of the governments, so any of them could play at any level. So it kind of makes it sometimes when one arm of government abdicates in its responsibility, they will assume the other will do it. So you have some political actors that will just not do so much, and that tends to affect. But in the private sector, it keeps growing, and people assess it at different levels, especially, and this is different from one part of the country to the other. There are some parts that is more of government facilities, especially the poorer areas in the country. Others, you have more private presence. Thank you.
Thank you so much for a robust conversation. Thank you, Swati, Beniam, and Las. We really appreciate this conversation. There's always so much to think about when you think of all the other parts of the world and the struggles and the trials and tribulations people are going through. But we really do appreciate your time this morning, evening, afternoon for sharing with us and enlightening us the most. So as we wrap it up, we have our last thoughts for the day. So things to keep in mind, as Swati had mentioned, this is the last of our health series presentations. We're so glad that many of you were able to join us. And for those who were not able to join us live or online live, all the recordings will be available on our webpage. So please feel free to tune in at any point if you'd like to have additional information, or if you'd like to know more, or if there's a conversation that you missed. For the most part, again, please do note the certificate of attendance will be sent in a few days. It will automatically be sent to all who attended for at least 40 minutes of this presentation. Our next round of presentations will take place on October 29th. We will be having our guest from New Zealand talking about Indigenous Maori approaches to healing and psychological research and clinical practice. Please note that will be 4 p.m. in New Zealand time, which is midnight in East Coast, 9 p.m. in the West Coast, and 6 a.m. somewhere in Central Coast. We will also have another presentation webinar on November 12th. That will be at 5:30 Gulf time, which will be discussing the developing mental health landscape in the UAE. And then we have November 21st. We'll also be having the Global Network of Psychologists for Human Rights discussion on how long does the war last? Lessons from Croatia. So stay tuned, and we look forward to seeing you again another point. And yes, I often mix up my time zone. CET is Central Europe time. So Please stay tuned and check your schedule and check your time zones, and we'll see you again soon. Bye, everybody. Thank you again.